Everyone, my name is Daniel Silberstein. I'm a physical therapist. I recently graduated from Turo, and I really wanted to get a better understanding of training. So in physical therapy school, they teach a lot about health, disease, the best way to treat, being able to differentiate patients that have musculoskeletal impairments from those that don't, but they don't emphasize enough about actual training, how to best train somebody to get them to become more athletic. And as a result, I decided to take the sign up for the NASM CPT. And as I'm going through this book, I realized that there's so many terms that could be overwhelming, confusing, or difficult to grasp if you don't have a background in physical therapy or kinesiology and so on. And I can imagine a lot of you guys are essentially do not have that background, or have been having a background in personal training, and just general training, general fitness, general exercise, but may not be as familiar with terms like pronation distortion syndrome or synergistic dominance or length tension relationships. And so that can be quite overwhelming. So what I really want to do is be able to put together a video to be able to explain the chapters in the NASM textbook in a way that will make it easier for you to understand and also more enjoyable to go over. Because the more you understand it, the more you're going to be able to apply it. So I want to start with chapter 6. I'm going to go through the textbook, and I'm also going to explain it and with a perspective based on my education and clinical experiences that I've had during my affiliations. So the first thing that we have to understand is the major difference between what a physical therapist or physician would do versus a personal trainer. There's a lot of tests in chapter 6, a lot of different fitness assessments. But what it really is important to understand is that we're not doing those assessments to diagnose. We're performing those assessments as personal trainers in order to create a baseline. Once you have that baseline, you'll be able to know, okay, how's this person progressed? But not just that. You have to think to yourself, if somebody's tight, okay, so what do you stretch? You don't want to just randomly stretch muscles. You want to be able to stretch the specific muscle that is causing the problem. So for example, if someone has difficulty with shoulder flexion in the sagittal plane, right, they raise their arm up and it's limited, they can't get it fully up. So now you have to really ask the question, well, why is it limited? Well, doing the squat assessment in chapter 6 will actually guide you in letting you know that. Certainly it could be the lats attached to the humerus as well as to the pelvis. So that if you have a tight lat, you're going to have difficulty going all the way up there. And if you do end up going all the way up there, you may actually compensate by doing exaggerate the lumbar lordosis. By doing an anterior pelvic tilt, you're essentially putting the more distal attachment of the lats on slack to allow you to get full shoulder flexion. Okay, so again, what you really want to do as a personal trainer is perform these fitness assessments so you could be able to identify what's tight, what's weak, create a baseline for yourself so that way you can see how the person has progressed over time. Now, we're going to start off with discussing what a subjective assessment is. What is a subjective assessment? And that's really just questioning. That's just asking the client questions. You're asking them a bunch of different questions: medical questions, lifestyle questions, occupational questions, medical, personal, and so on. Now, we have to understand what is the benefit, because when you ask a question, you don't want to just have a checklist of things to ask. You want to have an understanding of an exact purpose of why I'm asking this question. Right? So the first thing that you always want to be able to do is check out the PAR-Q, right? The PAR-Q, which is called the Physical Activity Readiness Questionnaire, right? So what is this questionnaire? Why is it important for you to give this to your client prior to starting an exercise routine? Well, the first reason really is that you want to be able to make sure that essentially this person does not have cardiovascular disease, right? So you want to make sure that this person does not have cardiovascular disease, and that's really what the PAR-Q is questioning on, right? One of the questions is, do you feel pain in your chest when you perform a physical activity? We know that chest pain is one of the most common things that occur as a result of exertion, right? So you want to assess that. You want to know, do they have chest pain at rest? Do they have a bone problem? If they have osteoporosis, you may want to change your exercise routine. You may want to provide exercises that promote bone growth specifically. Right in the earlier chapter, it talks about the difference between weight-bearing exercises, resistance exercises traditionally, that promote bone growth, that decrease the risk of osteopenia, that decrease the risk of osteoporosis, or potentially even help rebuild bone, versus exercises like swimming, running, which are more aerobic. I'm sorry, not running, but more swimming, bicycling, which are more aerobic driven and don't drive the development of bone as much. Okay, so that's really an important thing. And, so after the part Q, you really clear out the risk of cardiovascular. And not obviously not the only risk. You'll ask questions about, past medical history. Are you on any medications? And some of those medications may relate to to their cardiovascular status. The next thing you want to take a look at is their occupation. Why is it important? Why do you want to know what they do? So in the next chapter, it talks about extended periods of sitting. So there are three major elements that you want to consider if this person has a sedentary job. Number one, if they're sitting all the time, their hip flexors are tight, their glutes are stretched out, they're essentially, they may essentially be in that type of pattern, tight hip flexors, weak glutes, and they're likely going to be having a forward head posture. They're more likely to present with an upper cross syndrome. Right, and we'll talk about later the types of muscles that are going to be tight, those types of muscles that are going to be weak or stretched out or loose or underactive in that situation of forward head. In addition, if someone's sitting all the time, you can get a sense that their cardiovascular system is likely to be poor. Their ability to generate a lot of cardiovascular endurance is likely to be poor as well. So that's important. The next important thing we want to look at is repetitive movements. Now, when it comes to repetitive movements, we're thinking like, are you doing at a keyboard, increasing the risk of carpal tunnel syndrome, stiffness at the shoulders? Are you a painter who keeps his shoulders constantly in an up position as you're painting? It doesn't matter what activity you do. If you're doing something repetitively, what eventually will happen is that your body will adjust to that. You could be even somebody who constantly performs an activity with the same hand, with the same position. Someone constantly throws something in a certain direction. That direction is going to be more trained than the opposite direction. And as a result, that's going to create an imbalance. That's referred to as pattern overload. So that's important to consider as well. Dress shoes, right? And this is particular for females. You think about, they're wearing high heels, and what happens with high heels? The gastrocs eventually get tight. Gastroc soleus complex gets tight. The tibialis anterior gets potentially underactive or stretched or loose. And consequently, the person may develop a decreased ankle range of motion, talus roll joint. So now you have decreased ankle range of motion, and now this person is going to, for example, take a walk with regular flats. Well, if you have decreased ankle range of motion, and as you're walking, your body has to progress forward, your tibia has to progress forward, but it can't because you have a tight gastroc soleus. So what's going to happen? You're going to compensate with pronation. Hence, pronation distortion syndrome is a potential complication of wearing high heels for prolonged periods of time. And mental stress, right? If somebody is physically stressed, if someone is emotionally stressed, they are going to experience more. They are going to experience increased muscle tightness, increased muscle strain, and so on. And so that's important. Their blood pressure may be more elevated. Their heart rate maybe go up as well. So that's going to impact their cardiovascular status as well. And of course, recreation and hobbies. Whatever people do, essentially our bodies are molded by what we do. So when we do our postural assessment later on, you'll get a sense of, based on their recreational activities, based on their hobbies, based on their occupation, how has their body molded to their lifestyle essentially. The next thing we want to take a look at is past injuries. This is absolutely fascinating. It's so important because as a personal trainer, you're going to be meeting people all the time with history of ankle injuries, history of ACL injuries, history of shoulder impingement, history of low back injuries. So we have to really understand, what are the consequences? What happens if someone presents to us and says, I want to get stronger, I want to be able to run faster, I want to have a better agility, but I did have an ankle sprain in the past. How does that ankle sprain, how does that come into our picture? How do we now tailor our program or change our program based on the fact that this person had an ankle sprain? Well, as the book describes, there is a neural link between the ankle and the glute med and glute max. So think about that. If you have an ankle sprain in the past, there is now a disruption to the glute med and glute max. What does the glute med do? And what does the glute max do? They are both external rotators, abductors, and extensors. Okay, what does that mean? That means that every time you walk, right, every time you run, you're essentially, there's going to be a point you're in single leg stance, where all your weight is on one leg as you're taking a step with the other leg. Well, there has to be a balance. There has to be equal balance between your adductors medially and your abductors laterally. If there's an imbalance, it's going to lead to malalignments. Well, what's the other most common malalignment? It's going to be adduction of the knees. Well, why would the knees adduct? It's because the abductors, the glute med particularly, is weak, and it cannot generate that abduction force to stabilize the position of the lower limb. So here we can see a quite common pattern, an ankle sprain leading to adduction and internal rotation of the knee, essentially leading to knee pain because of the excessive compressive forces occurring, the abnormal forces that are occurring. The next thing we want to think about is a knee injury. Someone gets a knee injury. As a result, proprioceptive information to the knee is altered. Now, we know that the knee is, essentially the patella, the kneecap, is a floating joint. It's controlled by connective tissue, the retinaculum on the medial and lateral sides. You have the vastus medialis, the vastus lateralis. Those two muscles are stabilizing on the medial lateral sides. So, essentially, if you have an alteration in proprioceptive input to those muscles will not be able to tug equally on the patella, leading the patella to shift. Although the book doesn't mention it, it's a common cause of patellofemoral pain syndrome, malalignment of the patellar position. So again, another reason to know, this person has a previous knee injury. I need to make sure that their vastus medialis, their vastus lateralis, or essentially even broader, their medial and lateral musculature is well balanced, because it's likely that there's an imbalance. And imbalances are likely to cause patellofemoral pain syndrome or sorts of non-contact knee pain. Now, the other important aspect to understand is the idea that the knee is essentially accepting the brunt of the force from problems at the ankle and problems at the hip. We already said, imagine a woman's wearing high heels. She loses her dorsiflexion range of motion because her gastric soleus gets tight. She takes a walk. She's essentially compensating with pronation. Well, by pronating, what is pronation? Pronation means that you're taking the medial side of the foot and you're flattening it, or you're putting more pressure on the medial side of the foot. Now, you have two arches on the foot. You have the medial longitudinal arch, you have the lateral longitudinal arch. If the medial longitudinal arch is being compressed because you are compressing the medial side of the foot more, you're going to internally rotate and adduct. That's going to put pressure on the knee. Imagine at the hip. Imagine somebody at the hip, they have weak glute max, weak glute med, and their external rotators are weak, and so they tend to internally rotate because their adductors become more dominant. Well, what's going to happen? Their femur is going to internally rotate and adduct, causing adduction of the knee. So we can see that whether it's an issue at the ankle or whether it's an issue at the hip, we see that both can cause eventual problems at the knee. So again, it's important to understand that if someone's having knee issues, let's take a look at the ankle, let's take a look at the hip, and let's see if we can identify any muscle imbalances that potentially are contributing to that knee dysfunction. Why is it important to understand past surgeries? So the same reason it's important to understand past injury, you got to understand past surgery. Past surgery essentially means that there is an insult. Now, it's a controlled insult. It's an appropriate insult. It's a medical insult, essentially, but it's an insult, which induces an inflammatory response, which causes what? Disrupted neural input. And so we have to understand that as well as really altering all the same types of neural input. The next thing we have to look for is chronic conditions, right? Chronic conditions include cardiovascular disease, coronary artery disease, hypertension, high cholesterol, obesity, diabetes. Again, all these things, we have to be careful that if the client essentially has these conditions, we may have to look for a medical clearance just to make sure that it's okay. Medications. The next aspect here is medications. There's a lot here about medications. It talks about beta blockers, calcium channel blockers, nitrates, diuretic, bronchodilators, vasodilators, antidepressants. Right. So why do we have to know this? And this is actually a beautiful example that was given in our class, in our cardiopulmonary class. Imagine you want to assess somebody's ability to respond to stress, particularly a physical stress, exercise, right? You can measure the resting heart rate, which is a good assessment of somebody's cardiovascular status. But you also want to measure the recovery heart rate, because the recovery heart rate reflects how well does this person respond to the physical stress of exercise. Great. So you have them do some type of exercise, and then you want to monitor them. Then you assess. Well, how are you going to assess? You're going to either assess their blood pressure or take their pulse. Well, what does a beta blocker do? A beta blocker essentially will alter cardiac output. We know that cardiac output is stroke volume times heart rate. It's going to alter those things. As a result, will the pulse rate effectively reflect the stress of the exercise on the body? No. The beta blocker automatically will slow down the heart rate. It will decrease those parameters, therefore making your assessment of the pulse or blood pressure an inaccurate reflection of what the actual cardiovascular stress was. Right, so that's something to consider. So maybe we'll say, well, maybe a physiological assessment of the blood pressure is not as accurate. Maybe we'll turn to something like the Borg scale in a later chapter, a more subjective way of assessing intensity of exercise. So that would be one application of understanding the relevance, right? If someone's on a beta blocker, they're going to have a lower heart rate, a lower blood pressure, just naturally because of the physiological effect of the drug. So it's important to understand that. Right, so because we also know that a lower heart rate, a lower resting heart rate also reflects a better cardiovascular status. So don't confuse a lower resting heart rate as a result of pharmaceutical versus somebody who's athletic and is bradycardic simply because their stroke volume is so high and therefore their heart rate has to be lower in order to generate the appropriate amount of cardiac output. So the next thing we'll take a look at are heart rate and blood pressure measurements. We just mentioned that. We said that resting heart rate is a good way of assessing cardiovascular status, and recovery heart rate or seeing how the heart rate adapts to exercise. Great way of seeing how the body responds. In a later chapter, you'll talk about the GAS, which is a way of assessing stress, really looking at what is the effect of stress on the human body. And again, it's very important to understand how the heart rate will adjust or how the cardiovascular system will adapt to the physical stress of exercise. When assessing the pulse, generally we'll do the radial pulse. You want to be careful about the carotid pulse because there are receptors along the carotid area that could actually decrease the heart rate, especially if you put too much pressure. So generally just two fingers over the wrist, and you'll assess the pulse there of the radial artery. The next thing we'll take a look at is generally heart rates are going to be between 70 and 80. Males about 70, females about 75. So that's an important thing to consider. The next thing we want to think about is the target heart rate. So that's really fascinating. Target heart rate is really a way of helping guide where should this person be, or where are we within how much intensity are we incorporating into the program. Right, so when it comes to target heart rate, first let's just discuss the zones, right? So we have three training zones, zone 1, 2, and 3. Zone 1 is 65 to 75, zone 2 is 76 to 85, and zone 3 is 86 to 95. Right, so the question is, what zone should we train someone in? So we could do the straight percentage method, right? Straight percentage method, simply what? 220 minus the age gives you the maximal heart rate, and now all you got to do is just multiply the percentage by that maximal heart rate to determine what are the heart rate parameters for each of the zones for this specific individual. Then you could progress. You may progress from zone 1, 2, or 3, or based on their prior history, you may go straight to zone 2 or 3. So that's really a simple way of doing that. The alternative is really the HRR, heart rate reserve method, also known as the Karvanen method. And pretty much for that, you get the target heart rate by doing the 220 minus the age, which is the maximal heart rate, which is essentially equal to the maximal heart rate, minus the resting heart rate, times whatever percentage intensity you want to provide to this person, and add all that to your resting heart rate. The next thing we're taking a look at is blood pressure. Let's understand what blood pressure really is. Blood pressure is the compression of the blood against the arterial wall. Every time the heart beats, and that's described as systole, you have blood is propelled through the artery. It causes the arterial wall to bulge. That is what? Systole, right? That's reflective of systole. That's the bulging. That's what you're palpating for at the wrist or the carotid artery or any of the other arterial areas that are exposed and available to be palpated. Then, as the heart is relaxing through the process of diastole, you then have a recoiling of the artery. The arterial wall recoils, forcing the blood further. That recoil is what? The diastole section. And again, blood pressure generally should be less than 120 over 80. 120 over 80 is generally a healthy blood pressure. The next thing we want to take a look at is body composition. Body composition is important because it lets us distinguish between the amount of fat mass versus the amount of lean body mass. And there's different ways that we can really assess this. In general, there's three major ways that we assess this. And the first one is using the skin fold measurement, right? Pretty much is the skin fold measurement. And what we're doing there is we're taking a caliper and we're assessing a skin fold of the anterior bicep, the posterior to the tricep, obviously between the elbow and the shoulder. We're also going to get a 45-degree angle at the iliac crest and a 45-degree angle at the inferior angle of the scapula posteriorly. And this is all going to be on the right side of the body. Based on those measurements, you're then going to put into a formula and essentially get some type of composition. Again, somebody who's obese, you don't need to do this. It's actually inaccurate and not necessary. They already know they're overweight. It's not necessary to do an in-depth, evaluation like that, essentially pulling rolls of fat between the caliper. Instead, for them, it's more appropriate to do more of a circumference measurement. You've got a certain amount of girth. Fine, we'll work on it. Once there's an alteration or change in body composition, we'll see a change in that girth measurement. And that's a way we can track outcomes from the beginning of our sessions, from the beginning of the session to the, throughout the time that the client is training with us. The next technique is bioelectrical impedance, right? And pretty much what that is really, it's using the understanding that electricity flows through mass that has water better than it does through fat. In fact, fat serves as it impedes the conduction of electricity. And so based on how quickly the electricity is able to flow through the person, that is a measurement of the amount of fat, percentage of fat. And finally, the last technique that is actually the most accurate is referred to as hydrostatic weighing. Because it's the most accurate, we can imagine that this is something that's used only in the very, very high quality physiology labs. This is not within the reach of a typical personal trainer or a typical facility. And again, it's really based on the idea that fat will float, lean mass will sink. And based on where this person is, how much they sink into the water, or how much they're floating, we could determine based on mathematical calculations and sophisticated equipment where this person lies, how much fat mass he actually has. So the next thing that we're going to talk about is, we talked about circumference we said is generally good for somebody who's overweight, and you could do circumference of the neck, over the Adam's apple, over the chest, over the nipple area, over the waist, over the navel, or the lower portion of the rib cage, over the hips, over the widest portion of the hips, generally going to be the area of the greater trochanter, over the thighs, the widest portion of the thighs, about 10 inches above the kneecap to make it standardized, and the calf going to be the widest portion of the calf. The next thing we want to take a look at is referred to as the waist to hip ratio. The waist to hip ratio, again, the biggest thing that you got to really know here is that this ratio really helps guide whether somebody is at risk for cardiovascular disease. One of the things it's not mentioned in the book, but there's this whole idea of visceral fat, right? This whole idea of the difference between superficial fat versus visceral fat. Visceral fat accumulates within the waist, onto the organs, and versus fat that is, for example, found on the hips, versus the fat that, for example, may accumulate on the liver or the pancreas. Hence the term fatty liver. So if you have a waist to hip ratio of 0.80 for females or 0.95 for males and above, so what you're essentially at a higher risk of cardiovascular disease. And for BMI, also BMI is really just looking at your weight in relation to your height. That's really it. And again, what we know about BMI is that If you have a BMI of 25 or more, you're at risk of cardiovascular disease. What is considered obese? Greater than a BMI of 30 or about 30 pounds over the recommended weights. We're now going to talk about cardiorespiratory assessments. Now, cardiorespiratory assessments, the ideal respiratory assessment we want to perform is an assessment of VO2 max. VO2 max is truly the best way to assess because essentially you're forcing the person to go all the way to exhaustion, and now you're assessing the amount of oxygen intake. That is the best way to assess cardiorespiratory fitness. However, in many situations we don't have the sophisticated equipment. We also don't want to push the person to exhaustion. So instead, we use submaximal tests, which essentially is defined as a test that we make the person exert, obviously not to exhaustion, and based on their level of exertion, based on their physiological response to that exertion, we can then predict what their fitness level is, their cardiorespiratory fitness level. One of there's two tests really mentioned here. One of them is the YMCA 3-minute step test, and one of them is the 1 mile Rockport walk test. So let's just go over just a quick review of those two tests. The YMCA 3-minute step test is pretty much you have a step 12 inches high. You're going on that step on a rate of 96 steps per minute. So it's going to be up, up, down, down. You can use a metronome, 96. And after doing that for a total of 3 minutes, you're going to measure this person's heart rate within 5 seconds of completing it. Now, you got to measure that heart rate for a full 60 seconds. Why can't we do it for 10 seconds and multiply by 6? The answer is because your intensity went during the test to whatever level it was. Let's assume it was high. And then once you stop the test, your intensity goes all the way down to 0. So now we're talking about a recovery heart rate. So now your heart rate is adjusting constantly throughout. It's not going to be the same throughout this 1 minute, and therefore you have to assess the entire minute. After doing that, you go to the chart in the book and you look at the gender, then you look at the age range, and then you see what the pulse is. And that could determine whether it's excellent, good, above average. And then those values, excellent, good, above average, correlate to particular training zones. So for example, if we're talking about somebody is 27-year-old male, right? So that would be, and they had a heart rate of 55. So that would be in the excellent range. So now you just go to excellent. Excellent is going to be zone 3. So you know that you can train this guy into zone 3. So it tells you something about the level of cardiorespiratory fitness. However, if they were a 65-year-old plus person and their heart rate was 130, right? So then you know they're poor. So now you want to keep them into zone 1, right? So this helps guide what training zone you want to put this person in. So earlier we knew that we learned how to calculate the actual training zones. We learned how to calculate the actual training zones based on the person's individual maximal heart rate, but we didn't know how to know where this person's training zone should be. How do we determine what the current level of cardiorespiratory fitness is to figure out which training zone they should be in? So the YMCA 3-minute step test is really good in being able to help us know, okay, this person should start training in zone 1, or this person's really good, should be training in zone 3. The Rockport walk test, similar, it's another type of test. You're measuring the weight initially. You have the person walk for 1 mile as quickly as possible. You measure the heart rate exactly at the end of that 1 mile. Based on that, you can correlate it. You put that into the equation, and again, you'll get the figuring out of the zone. So now we talk about the next part of the chapter is posture and movement assessments. This is one of the more complicated topics. A lot of people, when I watched some YouTube videos describing how people felt about this part, they felt very overwhelmed because the amount of muscles that were mentioned in the book, and that can be really overwhelming. So one of the easier ways to deal with that is essentially to understand how all these muscles work together. So it's not just memorizing a bunch of muscles, but of some understanding why these muscles particularly, right? And to the best of our ability, I'll try to present as best as I understand why these muscles are the ones that NASM chose and picked out as the ones that are most implicated in these problems. So the first thing that we're going to talk about is the idea of posture. Now, when we talk about posture, the book describes this idea of length-tension relationship, it describes arthrokinematics, and it describes force couples. Now, let's just discuss what a length-tension relationship really is, right? Because it's used a lot in the book, and I found that it was not accurately explained. Let's give an example. We know that shoulder impingement is really common. Shoulder impingement is very common. One of the most common causes of shoulder impingement is not having enough space in the subacromial area, right? So you got the acromion of the scapula, you got the humerus, and there should be a space between the humerus and the acromion. That's called the subacromial space. Now, if the humerus translates superiorly, right? If it translates superiorly, it will compress the structures in that area. If it compresses those structures, it will lead to excess compression and shoulder impingement. So that's the cause of shoulder impingement. So what's the way to prevent shoulder impingement? The way to prevent shoulder impingement is actually to increase the subacromial space. Right? How do we increase the subacromial space? Well, there's a number of ways that we as therapists would adjust things, mobilizations, or teach the patient how to neuromuscularly activate things better. But one of the ways is actually to have the scapula posteriorly tilt. The scapula should tilt backwards. By tilting backwards, it actually opens the subacromial space. Now, it should tilt backwards. What muscle is responsible for pulling it backwards is actually the lower trap, right? It's the lower trap. Now, the lower trap is in the posterior region of the back. If somebody is forward head posture, they have forward head, and they become very kyphotic, so they're constantly in front of the computer typing, they're very kyphotic, essentially the lower trap gets stretched out. Well, if the lower trap is stretched out, is it that optimal length-tension relationship? We know that a muscle can generate maximal force when its actin and myosin filaments are optimally aligned. That's generally at the mid-range position. At the end-range position, either extremely short, for example, really all the way up here, or extremely long, the ability to generate force is minimal. However, at the mid-range position is when the actin and myosin filaments are optimally maximized and able to generate a lot of force. So the same thing with the with the lower traps. If you're in a kyphotic posture, the lower traps are stretched out. The ability for the lower trap to generate force to pull the scapula back is impaired. Therefore what? Therefore, the scapula doesn't get pulled back well. Consequently, as you raise your arm up, there's that impingement that happens because the scapula is not pulled back. That is a clear consequence of having a poor length-tension relationship. As an example, what would we do? We may do depending on what's tight, what's loose, but it could be, for example, if someone's thoracic spine is tight, we may do a thoracic mobilization or manipulation. Increase the mobility of the thoracic spine, allow it to extend more, optimize the length-tension relationship of the lower trap, maximize the ability to pull the scapula backwards, decreasing shoulder impingement. That's just an example from a physical therapy perspective of what a length-tension relationship issue is and how could it be addressed, at least through a physical therapy intervention. But imagine you could do the same thing as a personal trainer. If you can do, depending on the extent of course, but if you do foam rolling to encourage more thoracic extension, if you teach that person how to retract the scapula rather than having them all protracted, you could essentially you may potentially get similar results. And once that thoracic spine is able to extend and has that mobility, then lower trap has that ability to pull the scapula back. That's the importance of length-tension relationship, and that's why it's so critical. That's why it's absolutely critical to address that. The other major point that I describe here is force couple, right? So force couple are just like a bunch of muscles working together to accomplish a motion, right? So classically, as you raise your arm up, the scapula should upwardly rotate, right? What does that? It does lower trap, upper trap, and serratus anterior are the force couple that traditionally do that. Arthrokinematics is another term that's not well described and may be difficult to understand. This is where, it's the micro movements within the joint. So for example, this is the glenoid of the scapula. This is the humeral head. The humeral head, if you're doing abduction of the shoulder, the humeral head will roll up, but slide down. Those are orthokinematic motions, the rolling and the gliding. The reason why it has to glide downwards is because if it would continue to roll, it would actually fall out of the joint. So it has to glide down to maintain the center position of the humerus in the glenoid of the scapula. So again, that's an example of orthokinematics, but you can imagine that what dictates the orthokinematics? Muscles. So if muscles are not firing properly, if muscles are not operating properly, you're going to have issues with the orthokinematics there, right? So that is an important thing to understand. Now, what are the common distortion patterns? The textbook over here actually describes 3 major distortion patterns. They describe pronation distortion syndrome, upper cross and lower cross syndrome. Okay, so we're going to talk about this. Now, there's a big chart in this book here, really about pronation distortion syndrome with a bunch of muscles. Let's try to make it make sense. That way you don't have to memorize too much, right? So again, let's take a look at pronation distortion syndrome, and let's try to see if we can make sense of it. Okay, so first of all, let's take a look at the short muscles on the list. We have gastrocnemius, soleus, peroneals, adductors, iliotibial head, hip flexor complex, and bicep femoris, right? So again, let's just think about what pronation is. Pronation is the medial side of the foot is collapsing. The person is loading the medial side of the foot instead of moving sagittally through, right? So instead of moving through, they are loading the medial side and moving at an angle. Okay, now, why would they do that? Well, one of the reasons they commonly do that is because they have decreased dorsiflexor range of motion. They cannot progress forward because their gastrosoleus complex is tight. So what do? They pronate. One of the easiest things to remember is that calf tightness leads to decreased dorsiflexor range of motion, which leads to pronation compensations. Where do we see this? Where did we mention this earlier? We mentioned this when it came to the dress, right? So females that wear high heels, decreased dorsiflexor range of motion, therefore they're more likely to pronate in order to progress the foot forward. As an aside, pronation, because it's loading the medial side of the foot, it's actually pushing the big toe. And as a result, they're more likely to get a hallux valgus or a bunion because of that pronation. So you definitely want to take a look at, dorsiflexor range of motion. You want to take a look at gastrosoleus extensibility or flexibility. And we'll talk about flexibility at a later video in a different chat, addressing, flexibility, corrective, active isolated, or functional types of stretching. Now, we also want to think about, okay, so that makes sense. Gastrosoleus makes sense now. Why are the peroneals? Why would the peroneals lead to pronation distortion syndrome? So if you take a look at the picture on page 134 in the 6th edition, what you'll notice is that, again, like we said, the medial side of the foot is going down. Medial side the foot is going down. The peroneals. There's 2 muscles of the peroneals. Peroneal longus, peroneus brevis. Peroneus brevis attaches to the lateral side of the foot. Well, think about that. If you're going to lift the lateral side of the foot, that will cause the medial side of the foot to go down. Hence, tight peroneals can lead to flattening of the medial side of the arch. Peroneus longus goes from the lateral side of the foot underneath the arch and attaches to the medial side of the foot, but underneath. Therefore, it contracts. What do you think it's going to do? It's going to pull down. Therefore, it's going to pull the medial side of the arch downwards. So both peroneus longus and peroneus brevis both function to actually lower the medial side of the arch. So just from that perspective, gastrosoleus and fibularis longus and brevis, the peroneals, now make sense. Let's take a look at the next one. The next one is the adductors. We know that there is a kinetic chain. As I mentioned in the earlier chapter, kinetic chain means that you cannot differentiate what happens. Essentially, you cannot discretely change the ankle without altering the knee and the hip. In other words, it's one chain. One will affect the other. You can't have pronation without it affecting the knee or the hip. It's going to affect it. It has to. Because in a weight-bearing position, you're automatically stacking differently now because you're in pronation. So now when you're pronated, if you take a look at the picture, what you'll see is the knees begin to what? Internally rotate and adduct. They adduct. Hence, tightness of the adductors may be a potential culprit, right? So if you have tightness of the adductors pulling the knees in, well, just like pronation could essentially cause the knees to go inward, the knees going inward can cause the ankles to pronate, right? It goes back and forth. It's not one or the other. So you can have tight peroneals causing pronation leading to knee adduction, or you can have tight adductors, leading to internal rotation adduction of the knee, leading to pronation. All the same. The next thing we want to take a look at is the biceps femoris and iliotibial head. These are two muscles on the lateral side of the leg. Again, if you take a look at what adduction of the knee does, what is adduction of the knee? It means the knee is going medially. Well, if the knee is going medially, what does that mean? That means the lateral side of the knee is actually coming closer together, right? The femur and tibia are actually coming closer together because the knee is adducting. Well, if they're coming closer together, it must be that there are muscles on the lateral side that may potentially be short. Hence, biceps femoris, which is the lateral hamstring, and the iliotibial head, right? The TFL, essentially also tight on the lateral side. So both of those are tight as well. So understanding this, it actually becomes quite easy to remember pronation distortion syndrome. We know that pronation is commonly caused by decreased dorsiflexion range of motion. Hence, it's going to be gastric soleus issue. We also know that when there's an imbalance in the long muscles that go into the foot, we know that fibularis longus or brevis, they're going to automatically pull, they're going to evert the foot, essentially flatten the medial longitudinal arch. And then we also have to think, let's move a little up the chain, let's look at the knee. Oh, it's adducting there automatically by pronation distortion syndrome. The adductors may potentially be tight. And finally, we also have to think about, well, if the knee is adducting, that must mean the lateral side is actually getting close together. That must mean that the lateral muscles may get actually a little tighter, and that is your what? That is your TFL as well as your biceps femoris. The hip flexor complex, I'm not entirely sure how that works, why that does it, but it's easier. Once you understand the other stuff, hip flexor complex is easier to add. Now, lengthened muscles, exactly the opposite, right? We just said that that pronation distortion syndrome leads to adduction and internal rotation of the knee. Well, if it leads to adduction and internal rotation of the knee, it's going to lead to adduction and internal rotation of the hips as well. Why? Because then if the knees are rotating inwards, the femur will follow the tibia. Hence, stretching of the hip external rotators, stretching of the glute max and glute med, which are external rotators as well. Okay? Now, again, we just said that if the knee is adducting, it must be that what? The lateral side of the knee is getting shorter, but that implies that the medial side is getting longer. Well, what quad muscles on the medial side? Vastus medialis, hence vastus medialis. Now, we have to look at the foot. When it comes to the foot, we said fibularis longus and brevis, right? They play a role in everting the foot. They flatten the medial longitudinal arch. Well, what muscles help raise the medial longitudinal arch? We have tibialis anterior, and we have tib posterior. Tibialis anterior and tib posterior, right? Those muscles, tibialis anterior attaches to the top of the foot at the base of the first metatarsal, and the tib posterior as well. Tib posterior actually eccentrically controls the descent of the arch. So therefore, again, those two muscles will be lengthened in a situation where you're pronated. Let's take a look at altered joint mechanics. Again, it says increased adduction, knee adduction, which we know. By definition, pronation distortion syndrome is increased hip adduction, internal rotation, or knee adduction, or tibial adduction, internal rotation. It's all this adduction, internal rotation. Knee internal rotation, foot pronation, right? Foot external rotation, what that means is that the foot itself externally rotates, even though the tibia and the femur internally rotates. How do you see this, or how is it practical? This is called the too many toes sign. So if you stand behind somebody and they're very pronated, you'll be able to see all their toes laterally because their foot is so externally rotated. And it says decreased ankle dorsiflexion, decreased ankle inversion, right? Why? Because their ankle is so everted by the tightness of the fibularis longus and brevis. So that's the collection of pronation distortion syndrome. So if you just kind of understand where the attachments of the muscles are, what the actions of those muscles are, so then it becomes really easy to understand in a functional way, well, if someone's pronating, what muscles are likely to be tight, what muscles are likely to be underactive or overly long, and what are the potential biomechanical aspects that are present. Now, in lower cross syndrome, we can take a look here. It talks about short muscles of gastroc soleus, hip flexors, adductors, latissimus dorsi, rectus spinae. So what is lower cross syndrome? We define lower cross syndrome simply as an anterior pelvic tilt, right? So it's just the pelvis. You have the ASIS in the front, you have the PSIS in the back. When the ASIS go down and the PSIS go up, right? That is an anterior pelvic tilt. Essentially, an anterior pelvic tilt is essentially an arch. It's overarching of the low back. It's overarching of the low back. And classically, the most important muscles to really keep in mind are those muscles that essentially cause you to overarch, right? So what are those? Those are the tight hip flexors. When I think of lower cross syndrome as really like a cross, you have the erector spinae in the back that are attached to the top of the back of the pelvis, right? So if they get tight, they pull the back of the pelvis up. The hip flexors are attached to the front of the pelvis and they go downwards. So if they get tight, they pull the front of the pelvis down, essentially creating almost like a situation. Imagine the pelvis is a bowl of water. The bowl is spilling water forward. That is your anterior pelvic tilt. It's spilling water forward, right? It's spilling all the water forward. And again, tight hip flexors and tight arch spinae. And what does that mean? That means the muscles that pull the pelvis the other way are going to be weak. What does that? The abdominals, right? The abdominals attached to the front of the pelvis and attached go upwards. So they theoretically should pull the pelvis up. And the hamstrings and the glutes, they attach to the back of the pelvis and pull it down. These muscles try to produce posterior pelvic tilt or spill water backwards, right? Posteriorly. So that's an easy way to remember that those are really the dominant muscles. And then the other muscles they mention here are really because somebody in an anterior pelvic tilt tends to stand in a certain way. They tend to have hyperextension of their knees. And if you're hyperextended at your knees, I mean, you could Google a picture of what exaggerated hyperextension looks like. Your tibia also tends to be more shifted posteriorly. And if the tibia is shifted posteriorly, that's essentially what? Plantar flexion at the ankle, leading to tight gastrocsoleus complex. Right, so you may have a tight gastrocsoleus complex, you'll have tight hip flexors, you'll have tight erector spinae. Now, we also have latissimus dorsi here. Latissimus dorsi attaches from the shoulder, right, attaches from the humerus all the way down to the back of the pelvis. Now, if you have tightness of the latissimus dorsi, especially evident when you try to raise your arms up, or when you try to raise your arm up and all of a sudden you find yourself anteriorly pelvic tilting, that's really where the lats come in, right? So the lats will actually promote anterior pelvic tilt in a situation where you're trying to do shoulder flexion, okay? Because the lat is a shoulder extensor, so if you do shoulder flexion, you're stretching the lat at the shoulder, and again, if it does not have enough or sufficient extensibility, it's going to pull on the pelvis and actually cause an anterior pelvic tilt. So that's why it's listed there as part of lower cross syndrome, because you may actually get, if you got a really tight lat and you try to reach up, I mean, imagine every time you reach up to the closet and you got a really tight lat, that's going to cause chronic anterior pelvic tilt, eventually leading to potential injury. And that injury is really a consequence of overload, right? That chronic overload. And this is where a personal trainer can come in beautifully. You know, it's not that hard to assess whether somebody has a tight lat or not. If you notice someone has a tight lat, you notice that when you do the overhead squat assessment, they try to bring their arms up. Automatically, they start going into an anterior pelvic tilt. Boom. Right away, you potentially found a functional relationship between them trying to reach into the closet and them having back pain. Right, so in that situation, you could do stretching of the lats particularly. You could do activation, stabilization of the abdominals to counter the tendency of the lat to do anterior pelvic tilt, right? So again, those are fascinating concepts that really build off an understanding of this. And finally, the adductors are also quite common. I'm not entirely sure why the adductors are particularly tight in somebody lower cross, but like the hip flexors in pronation distortion syndrome, once you understand how everything else works, remembering one is not a big deal. And again, like it describes here, it says increased lumbar extension, which is that increased lumbar lordosis, and decreased hip extension. Because why? If you want to bring your leg back, which is hip extension, you need to have extensibility of what? Everything in the front. Because when you bring your leg back, everything in the front has to stretch. But if you have, by definition, tight hip flexors, you can't bring everything back. Therefore, you're not gonna have enough extensibility. The next big chart here is referred to as upper cross syndrome, right? So again, upper cross syndrome. So one of the easy ways to just group muscles in the upper cross syndrome, which is really defined as what? Forward head, right? Very forward head. So very, the scapulas are protracted, the head is generated, is jutting forward. right? One of the easy ways to just group muscles together or just thinking about the more global big muscles that generally people complain about, right? So you think about the sternocleidomastoid, the scalenes, the levator scap, the upper traps. Those are classically the types of muscles that are tight and generate that. You also have the pecs in the front here as well. Okay, so that could also generate that. So upper traps, levator scap, sternocleidomastoid, scalenes, pec major, minor. And we also have here as well the subscapularis, because again, think about it. One of the things that you want to encourage your client to do is open up, right? How do you open? You actually externally rotate. You externally rotate to open up. A lot of exercises promote external rotation as a way to open the chest. And actually, P&F technique, right? A P&F technique is actually a particular technique that is used to promote opening of the chest. And one of the techniques is external rotation in this position like this. So you're externally rotating, you're opening up. So subscapularis, which is an internal rotator, the lats, which are an internal rotator, right? Teres major, an internal rotator. These are muscles that would internally rotate. And so it's easy to see how they would promote it. I mean, do it yourself. Internally rotate. Automatically, by internally rotating, you're bringing your scapula forward. Okay, the muscles that are lengthened are most typically the longus colli. That's the deep cervical flexor. That's the type of muscle that most people say, like, imagine that there's a string going from the top of your head up to the ceiling, and it's elongation, right? It's all about elongation. Forward head posture is really a collapse of gravity. It's where gravity is essentially compressing you. But elongation, lengthening, is the cue that you really want to give to activate the longus colli. And then rhomboids, mid-traps. I mean, if someone has forward head and their scapula are protracting and shifting forwards, so then what do you think is being stretched all the time? The posterior musculature, right? So that's your lower mid-trap, lower trap, rhomboids. And serratus is going to be weak as well. Infraspinatus, right? If you're always internally rotated, infraspinatus is always going to be stretched. Teres minor, which is an external rotator, is going to be stretched as well, right? So again, you really want to think about that as well. And I think that once you think about that, it becomes much easier to link together. And the conditions, again, headaches, yeah. I mean, all these muscles connect to the head. And again, if these muscles are overactive, they're generating excessive input, they generate myofascial trigger points, that can cause headaches, bicipital tendonitis, rotator cuff impingement. This is all because the scapula, I mean, think about it. If your scapula are so protracted and you got weak lower traps, mid traps, and rhomboids, and you can't draw your scapula back and down, then how's your scapula going to, like we talked about earlier, posteriorly tilts? If it can't posteriorly tilt, then there you go. That's going to increase the risk of impingement. And so I'm going to stop the video here. I'm going to do another video discussing the actual static postural assessment, and then looking at the more dynamic postural assessment when it comes to the overhead squat assessment. And then we'll take a look at the kinetic checkpoints. We'll look at what muscles are active, what muscles are potentially underactive there as well. And then we'll look at some assessment tests, such as the Davies test, the push-up, the squat, and so on. Hope you enjoy. And again, if you have any comments or anything like that, certainly you can put them down below, and keep on learning.